All right, next up, we've got an amazing panel on healthcare. Curt Kirschner, who's with Jones Day, will be moderating that panel. And I actually met Curt when I was in Bangkok, when I met Laura Ellsworth at the same time. And he's been doing incredible work helping to lead the way on the issue of human trafficking within Jones Day and their law firm. He's also been instrumental in the ICD codes that track trafficking victims within the hospital. And he's worked with HEAL and the UN University and several other organizations as it relates to that. But the incredible work that he has done through Jones Day, and really, honestly, you'll see throughout the day, their entire team at Jones Day is just really incredible. And the other thing I'll mention about everybody you see that speaks today, they obviously work, but this is a passion of theirs. It's not just about a job, it's about making a difference in the lives of other people. And so Curt's a great example of that. And he's got an amazing panel who I've worked with, many of them for many years as well. And one area that Rotary wants to get engaged in to help you all get into hospitals, administrators, because Rotary obviously has administrators of hospitals, doctors, nurses in our clubs. We want to be able to expand the programs that you're going to talk about during your panel, and look forward to hearing all the things that you're doing and the hopeful message that you're going to give.
Great. Thank you, Dave. Thank you, Rotary. And thank you, Laura, also for all your work in putting this together and your leadership in this field. This is Curt Kirschner, and I get to kick us off. The topic for the panel is healthcare. What needs to be done to make a difference? And since I get to go first, I'll give you my short answer to that question, which is that while there is still much to be done, there is progress being made through a number of different leaders and practitioners in the healthcare field to address this issue. But a substantial difference is really being made in part to my two co-panelists, Hanni Stoklosa and Mindy Hatton. Hanni is the executive director and co-founder of HEAL Trafficking. She's an emergency physician at Brigham and Women's Hospital with appointments at Harvard Medical School and the Harvard Humanitarian Initiative. She's also director of the Global Women's Health Fellowship at BWH. She's an internationally recognized expert, advocate, researcher, and speaker regarding trafficking survivors through a public health lens. She's studied trafficking throughout the world. She's written numerous articles and a book on the subject, and she's been honored for her work in too many places to mention. Mindy Hatton is the general counsel of the American Hospital Association, the national organization that represents hospitals and other healthcare providers throughout the country. HA represents nearly 5,000 hospitals and other providers of care. Mindy provides leadership on all legal matters for the HA. And relevant to the topics today, Mindy is an executive sponsor of the AHA's Hospitals Against Violence initiative, which includes its robust anti-trafficking work. And based on my own personal experience of working with her, I can attest that Mindy has really led the charge through her work at the AHA in coordinating the efforts of the nation's hospitals to fight for trafficking survivors who interact with our nation's healthcare system. So before I turn it over to Hanni to give us an overview of healthcare's initiatives relating to trafficking, I wanted to provide some background about how the three of us came to work together, because I think it's instructive of how progress can be made in different aspects of the trafficking issue. So as Dave mentioned, I'm a partner at Jones Day. I happen to be a labor and employment lawyer. I've had the privilege of advising the HA and representing them on labor and employment issues for over 15 years. And so I've worked closely with Mindy in that area. In 2016, Jones Day launched its anti-trafficking task force and organized its first multi-practice, large-scale convening on trafficking in Houston. It seemed natural and important to involve the HA in those efforts. As has been widely reported, a large percentage of trafficking victims interface with the healthcare system at some point while they've been trafficked. And a sad, large percentage of them are never discovered, never identified, and then go back into a trafficking situation without any positive, without discovery or anything from the trafficking provider. So that seemed to be an interface that we could try to address and see if there's a difference that can be made in those interactions so that more trafficking victims can be identified, referred appropriately, and treated. So I invited Mindy to come with us to Houston. She graciously attended, and then I think both of us learned a lot from Hanni and others who were at the conference. And she took it upon herself to learn more and to engage with other healthcare providers who were fighting trafficking. And she coordinated all of those efforts under the umbrella of the Hospitals Against Violence initiative. With Hanni's leadership in the field, it seemed natural to also work not just with Hanni, but also several other practitioners in the field. And so we've been, the three of us and others have been working together, looking at the issues of trafficking and in the healthcare field. And I think we've, as you'll hear today, we've been making some progress, as I've mentioned before, lots more to be done. But I think there are some really interesting initiatives that we've undertaken to help try to coordinate the efforts among healthcare providers in dealing with trafficking. And I tell that story not just because it means something to me personally, but also because I think it's instructive how a nonprofit, a trade association, and a law firm, three disparate organizations, can come together and to fight a common enemy and make some progress along the way. So with that background, I'm going to turn it over to Hanni, who's going to provide us with an overview of the area of trafficking in the healthcare field.
Great, thank you, Curt. And as Curt mentioned, the perspective that I bring is I wear a number of different hats. So I'm an emergency medicine physician, and I really see trafficking on the front lines in my clinical care. I'm also a researcher and professor at Harvard Medical School. And as executive director of Heal Trafficking, which is now in 35 countries, I really have this kind of bird's eye view of what is happening within the healthcare and trafficking space across the globe. And I should also say, while I'm constantly immersing myself in the latest of research and listening to our partners on the ground, as Ambassador Richmond mentioned earlier, I think it's so critical to also just elevate the voices of survivors, and not only elevate them, but to center them in the work. And I can say that that's also just true for me personally. I've learned so much from survivors, not only survivor-informed research and survivor-based research, but in my interactions where I've had survivors give me feedback and on presentations, and to really correct the way that I think about this work. So I just want to put that out there as I get started here. In that vein of elevating the voices of survivors, I wanted to start off with a quote from a survivor. The survivor says, "I was praying for someone to ask me a question. I was praying for someone to ask me a question." And this is a survivor that was talking about going in and out of emergency departments, urgent care centers, and had interacted with healthcare a ton while they were being trafficked. And no one asked them a question about what was going on beyond the medical issue that they came in for. And this is not an anomaly. This is not unique. Every day around the world, trafficked people come in contact with healthcare. They may see a nurse at an urgent care center for a sexually transmitted infection. They may come to an emergency department like my own after a suicide attempt or a life-threatening injury from their job. Trafficked people may have a primary care doctor or a plastic surgeon or a dentist. What I think is so unique about the intersection with healthcare and what really healthcare can bring to the anti-trafficking world is that health professionals just intrinsically are trusted individuals in society. They're a trusted profession. And there's also precedence, right? We've seen this with child abuse. We've seen this with intimate partner violence, where when you bring healthcare to the table, we're able to really make a dent in the problem and make a difference in the lives of those that are experiencing violence. I just wanted to thank Dave again for harnessing the power of Rotary International. And we know that within Rotary, we have folks like healthcare administrators, as well as direct service providers along the full spectrum of engagement with healthcare. And I hope that this panel really ignites in folks the thought of, if you're not in healthcare, how can you better collaborate with healthcare, as well as to think, if you are in healthcare, in whatever role, what can you do to fight trafficking? I'm going to start off with talking about where the healthcare and trafficking sector response is today. And, I was thinking about this as I was preparing my remarks and realizing, 20 years ago, I would have nothing to talk about. There may have been sort of incidental reports. Maybe they would have popped up in the tip report of some interaction between healthcare and trafficking. But until really the last 10 to 15 years, we didn't have enough data to show that trafficked persons access healthcare. And now we do have that data. As Curt talked about, we know that the majority of trafficked people access healthcare at some point while they're being trafficked. And we also know why they're accessing healthcare. So someone, as I alluded to earlier, someone might come into healthcare with pesticide poisoning from working in the fields, long hours and pesticide planes flying over. They may fall off of a scaffolding on a construction site and then come in to a healthcare setting with those related injuries. They may have a sexually transmitted infection that's gone so far, and now that person is in septic shock. They may have bad teeth and they may need to access dental care at some point. So we see that not only do trafficked persons access healthcare and that they access healthcare for a variety of reasons, but also that they interact with all different types of health professionals. It's not just doctors, it's not just nurses, but it may be physician assistants, it may be nurse practitioners, it may be allied health professionals and dentists as well. So it's really not just the emergency department, though we definitely are on the front lines of caring for trafficked persons. Another thing that's critical to talk about here is education and awareness. I know Ambassador talked about this earlier, but if you just think about this, this is a relatively new topic for health professionals to becoming aware about. And there are all those health professionals in all of those professions that have been practicing for years and years all around the globe. And then we also think about those that are coming through the pipeline, that are becoming trained in their health profession, whatever that is. And so that represents a huge need to train all of those individuals. And thankfully, at this stage, we actually have a number of tools that are out there, a number of curricula that are out there for health professionals, many of them that are accessible online in multiple different languages. The International Organization for Migration has some great resources for education and training of health professionals. That was one of the first that was out there and created. Within HEAL, we're actually taking an assessment tool to look at all of the curricula that exist currently and see how much they align with kind of being comprehensive across the board, not just focusing on sex trafficking, but as the ambassador spoke about earlier, also forced labor, and making and seeing where do these curricula that we now have in abundance for health professionals stand in terms of being comprehensive for health professionals. The Department of Health and Human Services in the United States created a SOAR online training, which is also a really fantastic tool to get embedded in healthcare systems across the country. Another piece to the healthcare response that we can now talk about, because we're at this stage, is that health systems are increasingly recognizing that they need to have plans in place for trafficked persons when they come through the door. So it's all well and good if all the staff in a health facility have education on trafficking, they know how to assess for trafficking, but then what? they have this person that they've identified as being trafficked, and how can they help them to get the resources that that victim is looking for. And the key is really having those policies and procedures in place so that that response is not reactive but proactive, and those relationships in the community are already established. A number of years ago, in partnership with Hope for Justice, Heal Trafficking created a toolkit for health systems, which has now been downloaded in 35 countries around the globe. And then on a policy side, there are states like New York State in the United States that have actually mandated that their health systems have a plan in place. I can't underline how critical this piece is, and also how a growing number of health systems have really stepped up and put those policies in place. In my own health system, we took the response of really creating an umbrella for anti-violence response. And so our trafficking response is right next to our intimate partner violence response, sexual assault, and child abuse, because there are so many common denominators, including the players that we end up engaging along the way, as well as trauma-informed approaches. So another piece that's really come out of the healthcare sector is this need for a public health approach to trafficking. And I know a public health approach to trafficking was highlighted in the TIP report, I think it was 2 years ago. And this approach is what a lot of us are already doing, but really not just thinking about how can we be reactive and to intervene, but how do we look upstream, and how do we think about prevention in an evidence-based way? And I know there's a panel that's later on today that's going to be talking about the prevention piece. In terms of where we are today, and just kind of looking across the board and across the globe, gaps that exist include responses to males, responses to LGBTQ populations, indigenous populations, forced labor, organ trafficking, and then on the healthcare side of things, specifically gaps in terms of professional response and dental care, those involved in substance use disorder treatment as well. I'm going to talk now about the impact of COVID on trafficking. And I know that there have been a lot of reports that have been published over the course of the pandemic that are coming out globally, but specifically in healthcare, how has this impacted vulnerability, and how has this impacted our response to trafficked persons in the pandemic times? So certainly, as we've seen in many international reports, and then are also hearing from our network, we hosted a number of forums to just hear from the front lines across the globe what people are experiencing in healthcare. And first of all, the effect of family life that COVID has really created that home environment as being a pressure cooker in many ways. And this results in increased violence. We're seeing in my own emergency department, the severity of cases related to all forms of abuse, including trafficking, the ways that they end up presenting to the healthcare setting are much more severe during these pandemic times. And this is, secondary to a number of reasons, including financial stress in the home, overcrowding within residences, and then also, unchecked abuse. So traditionally individuals are coming and going in society, children are going to school and interacting with educators, and there's less opportunity to intervene early during this pandemic than there is traditionally due to just being isolated. Children are definitely using the internet more, and it's not just playing out in terms of sex trafficking, but there's also increased contact with fraudulent online jobs that they're in contact with, not just children, but also adults. On the economic distress side of things, this has definitely led to an increase in labor exploitation and trafficking. And caregivers may even allow children to engage in hazardous child labor, such as work with dangerous machinery or work in an unhealthy environment because they just need to make ends meet and to survive. We also see this play out with sexual exploitation and trafficking. And then finally, in terms of traffickers, some individual and the perpetration side of things, because of increased financial stress, may need to turn to more coercive actions in order to be able to make ends meet as well. So this isn't just on the victim side, but also on the trafficker side. And then specifically in terms of the healthcare response, our healthcare systems are just simply overwhelmed. I know many of you see the headlines. It is so real, and COVID has taken the primary focus. And so, maybe prior to COVID, health systems were thinking about building their policies and procedures on trafficking, but really it's just survivor mode and making sure that we're taking care of all of our patients with COVID and keeping them alive. Also overwhelmed social service agencies. So my options in terms of where I can refer somebody when they're being trafficked, and that's identified, are so limited, including housing options. We also see that law enforcement agencies are understaffed during these times as well. So I don't want to say that it's all bad news, because I'm a realist, I'm an optimist, I'm a pragmatist, I'm an emergency medicine physician. So I do also see the positive in situations. And I do think that there are some silver linings that COVID has allowed for within the healthcare sector response to trafficking. One of them is that because of policies where people were only able to bring back that individual when they actually do come to a healthcare setting and aren't just accessing telehealth. I don't need an extra excuse to try to kick out somebody who I'm worried might be exploiting my patient. It's just across the board 100% policy that only the patient come back. And so that's actually, it's kind of a double-edged sword in many cases, but particularly when it comes to identifying exploitation, it's allowed for more ease in conversation, really having that privacy to be able to ask the questions without this extra layer of having to remove another individual. We also see that telehealth is a huge opportunity to assess for exploitation. So, this plays out in a number of ways. One is just like increased accessibility to health professionals in general. Those individuals that used to have to worry about transportation, childcare, or what have you, are now able to access healthcare in greater numbers. And then there's something just so unique in being able to see somebody in their home environment that gives you clues that you may not have had otherwise about that person's situation. And that helps in their healthcare across the board, but also in terms of identifying potential exploitation. And then finally, essential workers, many of whom may be experiencing labor exploitation and some of whom may be trafficked, have been increasingly recognized as those individuals that need to have access to COVID testing and vaccination. And of course, this is jurisdiction dependent, but is there, and this is more of a question mark and something that I'm in discussion with colleagues that work in migrant health more than I do in my clinical capacity, but are there opportunities with that increased access to specific COVID related resources for essential workers that may allow us opportunity to identify their exploitation? So where do we need to go? So given what I've shared in terms of a snapshot of the state of the healthcare response to trafficking today, and then layered on that, where we're at with COVID and healthcare and trafficking, looking towards the future, I mentioned some gaps on the education and training side of things and response side of things. I really do, as we surveyed our network, we just recently surveyed our global network of health professionals across the globe. And what we're seeing is that so much of the resources that are available to healthcare are concentrated in North America, as well as the United Kingdom. And how do we expand that globally? How do we make sure that health professionals across the globe not only have the education that they need, but the policies and procedures to support them, as well as the resources in their community to be able to refer their patients to? We also need global research to better understand the intersection of health and trafficking. There is global research that tells us, health consequences of trafficking, but in terms of where those opportunities are for health professionals to respond, that research does not exist outside of North America and the United Kingdom, and we need to fix that. We need more data to really understand that nexus. We also need to make sure all health professionals are educated on trafficking, and given the accessibility of online resources, there's no reason that this shouldn't happen. And while I'm not always in favor of mandating things, I think that an excellent example is Texas, where they have a mandated education health professionals on trafficking law that was one of the many states that's featured in the recent Jones Day report that gave us a snapshot of various state laws. And in Texas, as in response to this new mandate, in just a couple months' time, over 30,000 health professionals ended up getting trained on trafficking. You know, that's not enough. As we talked about it, they need to have policies and procedures, et cetera. But when you do have a mandate for education, it can make a really big difference in just raising that baseline level of awareness in a sector that's so critical in this response. We need more policies and procedures to be in place in healthcare systems. When they're not in place, I could give you so many examples, but you know, at some turns, just ad hoc responses have resulted in arrest or deportation in some cases when health professionals didn't know which law enforcement to contact for a patient, just to give an example. So there's real harm that can happen when there's a little bit of awareness, but not the tools and not the protocols in place. So I would just really encourage, as those of you who are interfacing with healthcare leaders and those of you who are healthcare leaders, to think about how these we can have universal policies and procedures in health systems. We also need to do a better job in elevating the voices of survivors in the healthcare response, and to really have that nuance, as Ambassador Richard talked about. They don't always disagree, but to have to hear from those variety of perspectives. You know, it's trafficked persons, in addition to looking at the data and intimate partner violence, it's trafficked persons, trafficking survivors that have taught me that it's not enough to just ask questions, that doing a checklist of questions matters less than really being there and showing that you care to an individual. Cultural shifts. So within emergency medicine and all of healthcare, we really need to take on a trauma-informed approach. It's something that I think trafficking can be an opportunity for healthcare to kind of wake up to the fact that we need to make sure that we're treating all patients in a trauma-informed manner, and also to be aware of our biases. Another thing that we've heard over and over again from survivors is that, particularly just to call out male survivors, that they may not identify that they're a victim, and some of that is gendered. And also a health professional is used to, you know, maybe it's media portrayals or what have you that they're informed by, but a health professional may not think of a male at all as being trafficked or potentially experiencing exploitation. And so as part of the education piece, it's also this opening health professional eyes to the biases that we have as human beings towards what trafficking might look like. And that's, you know, that has a gender, that has a race, that has a behavior that we make assumptions about. And how do we really address that in building healthcare's response to trafficking? So my vision is for a world where every victim of violence, including trafficking, who interface with healthcare, should be recognized and receive the care they need. Just to go back to this quote from the survivor, I was praying for someone to ask me a question. How will we heal the world of trafficking? I would argue by collaborating with and equipping healthcare to respond to trafficked persons. So thank you so much for this space, and I'm going to hand it over to Mindy.
Thank you, Hanni, and thank you, Curt, and thank you, Rotary, for having us today. Curt mentioned that I am the General Counsel of the American Hospital Association, and we represent nearly every hospital in the United States, and certainly every flavor of hospital, as I like to think of it, is under our wing, and we're happy to have them. In addition, one of the parts of our association includes the Association of Nurse Leaders. And that's an organization that's been very invested in the issue of human trafficking for a number of years, and because I think we all recognize how critical nurses are to human trafficking. And I know Hanni's a doctor, but there are lots of nurses who are on the front lines who care passionately about this issue. And we work very closely with our Association of Nurse Leaders. I want to start off by giving you just a little bit of background about how we at AHA got into this issue. And it really started in 2016 when, in response to two very horrific mass violence events, our Board of Trustees asked us what we could do to help the hospital community step up and take a more active role in combating violence. And I was asked to lead that effort. In thinking about where we could make a difference, we really focused on what are the problems that are bound to show up on the door, on our front doors of America's hospitals. And of course, human trafficking, as you've heard from Hanni, was a natural. Both Curt and Hanni mentioned how often it is that those who are victims of trafficking have some kind of contact with the healthcare system, and often that is hospitals or their outpatient departments. And we also thought that we had the ability to make a difference. And we are, of course, greatly aided in that effort by our partnership with both Hanni and Jones Day, particularly with Curt. And you'll hear more about that. But it was really instrumental to us being able to ramp up and focus on human trafficking in a way that I think has made a difference. We were also aided in the fact that this is a bipartisan issue. So the administration's Office in Trafficking in Persons has worked very closely with us and their leadership and partnership, and as Hanni mentioned, their training has also been a significant source of assistance as we were ramping up our efforts and trying to focus on what we could do to help hospitals become more knowledgeable about human trafficking and develop their own programs. We also discovered, one of the first things we did was we have such a vast membership, is we looked to see what hospital systems were already deeply engaged in this and what we could learn from them, and most importantly, what others could learn from them. And so hospital systems that you're probably familiar with the names Common Spirit, Ascension, Mass General, and even Allegheny were some of the first that we came upon that had developed human trafficking programs within their systems and had developed educational materials and were passionate about this issue and about combating this issue. And I believe Curt mentioned that one of the first projects that we took on, which was really inspired at the conference in Houston that Curt mentioned, but we really were able to pick up the ball because of the help of those at Catholic Health Initiatives, which is now part of Common Spirit, and Mass General, who helped us develop a human trafficking code that we use for the ICD-10 system. Now, ICD-10 tracks healthcare statistics, and you actually heard the ambassador talk about the importance of measurement, because if you really can't measure it, you can't improve it. And so getting the efforts it took and the partnership it took with Hanni, Curt, and Catholic Health Initiatives and Mass General to finally win approval for this human trafficking code has been very important in terms of being at least have a mechanism to be able to measure it. I can't say it's fully in use yet, but it's there. It's there and has great potential. One of the other things that we did that was really eye-opening, and I will admit we stumbled into this a little bit, and again, the help of Jones Day and HEAL was absolutely instrumental, as we did a convening of healthcare providers a couple of years ago, where we invited a wide swath of, not just hospitals, but a wide swath of healthcare professionals, as well as the administration, to join us in thinking about and helping us plan about how the hospital field could be more effective in this arena. And one of the most surprising things to me about that convening, which, remember the days when we could do things in person, it was actually in person, was that people who had been working in this field, who knew of one another, had never actually met one another. And so it was really inspirational to see people, again, who knew the work, who had been doing the work, but had never actually personally connect and really begin to bond and think about this. And out of that effort, we developed an advisory council that meets a number of times a year, where we can share ideas, we can share issues, we can share inspiration, And it's been, I think it's been enormously helpful to us in being able to maintain that kind of contact with the wider community, again, giving us inspiration. Because one of the ways that hospitals, we've found that one of the ways to incite hospitals and encourage hospitals to develop programs like this is to be able to show them a successful program in a kind of hospital that they recognize, and how it got started and how it worked. And that kind of inspiration has been so often in our field the real catalyst for another hospital to pick it up and run with the ball. And that's been true in human trafficking. A major partner that we have in this effort are state hospital associations. Every state has its own hospital association. And Hanni mentioned Texas, because Texas has really been an outstanding example of an association who really picked up the ball, particularly after the legislation was passed, to help their members understand and develop programs on human trafficking. And as you can imagine, Texas being a border state and the other kinds of issues and businesses that in Texas, you really create a lot of opportunities for human trafficking, and having robust programs to identify. And as Hanni mentioned, it's so important to know what you do after you identify a victim of sex trafficking. Having that association pick up the mantle and do yearly trainings and yearly meetings and other kinds of outreach with their members has been so instrumental. And I just want to mention, other state hospital associations are also stepping up to the plate. Just today, the Virginia Hospital, the Hospital Association in Virginia, where I live, released a public resource, which is a manual for hospitals to support providers and victims. And this is emanate from a task force that the association had on human trafficking. And again, how they thought they could help the hospitals in Virginia, again, develop or augment their programs and really, again, make a difference in this space. The only other example I want to give you is one that Curt and I discovered, which was when we were thinking about how to expand this to other types of hospitals. We realized that one of the types of hospitals where we had fewer examples were some of the elite academic medical centers. And so we both are fond of Cedars-Sinai in Los Angeles for any number of reasons, not the least of which is because both their CEO and their general counsel are just leaders in every area you can think of. And so we went to talk to them about developing a human trafficking program because we didn't think they had one. And it turns out they didn't think they had one either. But when we asked them the question, and they did a little research, it turns out that they had a very robust human trafficking program that was organic. And again, it was a group of dedicated nurses who saw a need, who stepped up and really out of their own pockets and their own inspiration developed a program that the front office didn't even know about. And of course, once the front office realized it was there, they developed, they gave them resources and recognition and really grew the program because they were so proud of it. But that's just, I think that's just, one example of the kinds of things that hospitals are doing that sometimes don't get the recognition that they deserve. And we were so glad that we could help seniors along in that effort. As Hanni said, there is still so much to be done. And of course, the historic effort we have now in combating the COVID-19 virus doesn't make that any easier. But the issue of human trafficking, the issue of violence is actually not made any better. And as Hanni pointed out, is probably made worse by the virus. So there's still a lot to do. So we're planning another convening again to try to, again, accelerate these efforts. This time it'll have to be virtual, not in person, unfortunately. But we at the American Hospital Association, and again, our nurse leaders at AONL are really committed to this effort. And again, we're so proud to be able to have a partnership with Hanni and Curt and Jones Day to be able to combine these kinds of resources to really make a difference in an area that really it's so important that that we focus on this and we set goals and we have robust programs to combat human trafficking, because in the 21st century, there's really no excuse for not focusing on this with every available resource we have. So Curt, I'm going to turn this over to you. Thank you.
Great, thank you, Mindy. And I am going to share my screen here just to show you some of the materials that we've been talking about. So from a law firm's perspective, from Jones Day's perspective, what do we bring to the table? So you've heard from Hanni, a physician, and everything that the nonprofit Heal Trafficking is doing, and Mindy, of course, from the perspective of hospital leaders and the ability to bring together so many different healthcare institutions in the U.S. To try to achieve universality of best practices, and they both have obvious roles here. So what does a law firm do? And so some of the things that we can do is just to help with connectivity, because I do think having disparate organizations partner together, we can learn from each other, we can help fill in gaps, and as a team, I think we're stronger. And I think one of the things that Jones Day has done and can do is, because of all the relationships we have with different healthcare institutions, we can support their efforts in this area and get them involved in the HA's work and provide that, provide those connections. And then through the Hospitals Against Violence initiative, by being a part of that, by being on the advisory council that Mindy mentioned, we're not just inspired by the work that's going on, but we also learn about what opportunities exist to try to fill in the gaps to make it easier for the providers to do their work. So for example, there was a discussion about Mindy mentioned the ICD-10 codes initiative that the HA led and actually got those adopted a couple of years ago. We provided some legal support and review for that process. Again, we weren't the drivers, but we helped support that effort, and that was a great initiative to be a part of. Most recently, we've been working on a project that just got published that's been referred to before by Hanni, and called Human Trafficking and Healthcare Providers, Legal Requirements for Reporting and Education. So the genesis of this was that through the advisory council, we were talking about where are the impediments, where are the opportunities to try to help support this effort. And what we learned is that each state has some variant of a reporting obligation for if you see certain patients who fall within certain categories, you have an obligation to report that patient to a particular governmental entity. And oftentimes that applies to child abuse victims, but it's also other kinds of reporting requirements, whether it's domestic abuse or gunshot victims. So with respect to trafficking, there is no one size, one universal reporting obligation. Each state has a different approach to that. Sometimes they're consistent, sometimes they're not. Sometimes they have the same type of location where you report the victim, sometimes it's different. And this patchwork of different laws becomes very difficult to navigate and keep on top of, particularly if you're a provider that operates in multiple states. And some of the larger healthcare systems are multi-state. And some of the newer providers that are focused on telehealth, which is particularly important in a COVID era, operate across state lines. And how do providers keep track of where they're supposed to report and what can they report? And this is a very important legal issue, because when a patient goes in to see a provider, there are lots of confidentiality obligations with respect to that patient's interactions with the provider. If the provider has an obligation to report, then that supersedes the patient confidentiality restrictions, and the provider can safely report that to the governmental authority if they suspect that the patient is a trafficking victim. But if it's not required under the law, then HIPAA and other state confidentiality provisions may prohibit the reporting from occurring. So knowing what is actually required to be reported is not just helpful guidance, but it's really important. Legal restrictions are lifted if the legal requirement exists to do the reporting. So it's very important for the provider to know exactly who can be reported and under what circumstances and to whom. And when these laws change from one state to another, it's very important to try to help provide some guidance to that. So we heard from Hanni and others on the advisory council that this is really a deficit that exists. So we undertook to develop this comprehensive report that tracks federal law as well as each state's laws with respect to who can be reported, who must be reported, and to whom. And the other thing that we cover in this report is what obligations do healthcare providers have for educating their workforce with respect to trafficking. So this is not universal by any means. It's really just a handful of states that currently provide this, Texas and others. But what are the educational obligations that are imposed on healthcare providers? And this report also tracks those by each state. It's hopefully a very usable tool. It's easy to navigate. You just look at the state that you're in or you're treating patients in, and then you can see what obligations flow from that. We published that on just earlier this month on January 11th. It was an achievement of a lot of hours and work with different Jones Day attorneys. We had contributions from several different attorneys who were contributing to this, but I do want to call out one in particular, Taylor Goodspeed, with whom I've worked closely. She really led the charge in pulling together the report. We published it. It's available on our website, free of charge to anyone who can access it. And it was published also and made public on the same day by AHA and by Heal Trafficking on their websites. The goal is to get it out there and make it available to as many providers as possible so that it can be as much use as possible. So just wanted to cover a couple of things that we've discovered from a legal perspective relating to these obligations and sort of where are the opportunities for moving forward. So first of all, just having so many different laws in this area, I think it sort of argues towards a more some more standardization with respect to what the reporting obligations are. It would just, there's no reason why there has to be 47 different standards for healthcare providers in this area. And so hopefully over time we can move to a more universal standard. I think that would be a lot easier for providers. Secondly, the laws are fairly consistent and robust with respect to child victims, but much less so with respect to adult victims of trafficking. So it would be helpful, I think, for the laws to reflect that if you find that you're dealing with an adult patient who is trafficked, having a more consistent manner of being able to report those victims without obtaining their consent would be helpful. I mean, you can always make a report if you have patient consent, but in a trafficked situation, that could be difficult to get, particularly if the trafficker is with them. So it's helpful to try to address adult victims of trafficking. And then the other area that is fairly absent from a lot of these is the issue of labor trafficking. A lot of the trafficking laws focus on sex trafficking, And that is certainly something that needs to be covered, but there's very little attention from a legal perspective paid to labor trafficking. And so I think that's probably an area of opportunity as people are looking at updating, different states are looking at updating their laws. And then of course, as Mindy mentioned and Hanni mentioned, there are relatively few states that have educational obligations. And what we've seen in Texas is that actually can make a real difference in terms of the prevalence of training and awareness that occurs within that state when there is an educational obligation under the law. So just to sum up my portion here, there's a lot going on in healthcare with respect to trafficking. It's been a real privilege to work with Mindy and Hanni specifically, and more broadly, all the members of the advisory council. I've learned a lot, and I think there's more to do, but there's real progress being made. It's both very, very inspiring to do this work, and we're at part of Jones Day. We're very glad to be a part of this initiative. Shown on the slide here are the websites and the links for the HA's Hospitals Against Violence, where you can see a lot of the resources that have been published by the HA. Heal Trafficking, and then also our the link to our report that is on the Jones Day website with respect to human trafficking and provider requirements for reporting and education. So with that, I'm going to turn to questions and answers. As I look those up, Hanni or Mindy, anything you want to add to what I've just said?
Curt, let me just add. You were so thorough in commending Taylor. Laura Castellanos has really been leading this for a number of years. Job and has been committed to this effort really since its inception.
Okay, Hanni, anything from you?
No, only to say, I was trying to let Mindy know she was echoing a little. Am I echoing as well?
No.
Huh. Okay. Anyway, I was just going to say, I'm so glad we have this opportunity to present this example of what is possible when you have multi-sectoral collaborations. And, while I was speaking specifically in many ways in my remarks to what can health professionals and the health sector do, I think it's also the question of how those outside the healthcare sector can create collaborations like this. And I hope that by sharing a lot of the detail of this model and what we've learned from creating this collaborative model can be replicated in other countries. So I'm really glad that we had this opportunity to share. And thanks so much for giving us this stage.
So
Can I ask a quick
Sure, Dave.
ask a quick question? One question that's been brought to me when I heard about this panel that was coming up was, obviously we have the IDC codes that relate to trafficking, but a lot of times the traffickers live with that person and they know what those codes mean. Have we addressed that?
The traffickers are I think they're unlikely to see the ICD-10 codes. But Curt mentioned the HIPAA, which is the Comprehensive Health Privacy Law. And so HIPAA has, and I think Curt mentioned, and Hanni mentioned how the providers providers already have really protocols in place dealing with a number of sensitive issues, whether or not somebody tests positive for the AIDS virus, for example, whether or not somebody's a victim of child abuse, which has been in the ICD-10 codes. So some of the partners that we have on our advisory council have been very active in reminding providers of their obligations around both discretion and confidentiality when they're dealing with a sensitive issue like trafficking. But providers, at least hospital providers, have a lot of experience, again, with sensitive medical issues and other sensitive issues, and how they can both report those so they don't go unnoticed, but also make sure that the victims are protected from any retribution as a result. I don't know, Hanni, if you want to add anything.
Yeah, I totally agree. This is not unique to trafficking ICD codes. And I think overall, I'm really excited. You know, they're relatively new, but really excited to see how this helps us to answer some of those research questions that I put out there. Like, what is that healthcare interaction look like in other countries? And we're hopeful that the ICD codes will be adopted on the international level as well. And to say that, you know, for those of us who practice here in the United States context, the Cures Act that was recently passed, which allows for open notes, has been another opportunity for these discussions about how do we both make sure that patients have the information that they need and to provide patient-centered care, and also protect those sensitive populations, of which trafficked persons are one of them. And I know in my own health system, there are another protections that we can put in place to protect sensitive records, whether it be HIV, AIDS, whether it be somebody's mental health record or what have you. So I feel confident that health systems are figuring this out in our electronic health records in this current stage. And, you know, those best practices do exist, and we can point to them as it relates to these trafficking codes.
Can I ask just one more quick question? Hanni and I have had this conversation offline, but Rotary, one of our things that we want to engage in with the Rotary Action Group is the healthcare sector. And where we may have providers in our clubs, we may have doctors and nurses in our clubs that aren't dealing with this issue. And how can we get more engaged? How can we get our doctors and our healthcare providers that are in Rotary engaged in the issue and partner with you?
I think that's a great question. And I think it's first knowing, starting with where your power exists. So whether that's maybe you're in the front office in the C-suite, maybe you're a health professional, but really seeing where is your opportunity in the kind of range of different things that we mentioned. Maybe you're a medical educator and you really want to take on making sure every layer of staff in your health facility is aware of what trafficking looks like. It all needs to happen. Every health system needs to have policies and procedures. We need to be connected to the community resources. Education needs to happen. But the question I would ask is, like, you should do something. And then what is your unique kind of inroads with healthcare? And I would recommend starting there. I would also say that I think really critical is having leadership buy-in, and I know Mindy can speak to this as well, and also the voices of survivors. So learning from survivors in your community, they can tell you better than anyone else how they accessed healthcare, and having their voices when you're trying to get buy-in from senior leadership or from other staff about how important it is that health professionals be trained. It's so much more powerful than me as the doctor saying this is important, right? To hear a survivor's lived experience is just so powerful. So I don't know if my other panelists have anything to add to that, but.
Yeah, and we at AHA, we'd love to have the doctors, the administrators, and the others involved in the hospital field contact us, because we have a number of ways that they can get involved. We have an advisory committee on violence that includes issues of human trafficking. We have other committees that touch on this issue, and we have a annual day where we encourage healthcare professionals and hospitals in particular to talk about and to share on social media the efforts that they're within their own hospital that they make around any sort of violence, whether it's workplace violence, whether it's human trafficking, whether it's gun violence. And I think that's a wonderful way to get involved and to let others in the field become aware of what you're doing and become aware of what others are doing in a way that both, in a way that both illustrates best practices, but I think illustrates the commitment and pride that the hospital field has in the kinds of efforts that they undertake every day to protect their communities from all sorts of violence.
The one thing I'd add to that is that if you have an individual, a physician or a nurse or whomever who wants to get involved, another place to check out is the state hospital association. As Mindy mentioned, there's been some really terrific work that's being done at the state level with initiatives already in place. But we've also seen examples where people are interested in the area and there's no such program in the state association and they create one. It can be a real opportunity to try to band together and work together. You know, the kind of things that Rotary is embedded in your organization of bringing people together for the collective good. People can do that through their state associations as well. There have been a couple of questions that come in that I've just wanted to tee up for the panel. One is whether COVID has actually reduced the incidence of trafficking. And Hanni, I don't know if you have any perspectives on that.
I wish I could say it were so, but no, unfortunately, everything that we're hearing from our international partners and those in the US context, and particularly in healthcare, is that there is not only increased vulnerability to trafficking due to some of those family dynamics I mentioned and economic pressures and decreased mobility, but really an increase in trafficking, not just the vulnerability. I was trying to be optimistic and sharing that maybe there are new opportunities for intervention in the healthcare sector that COVID could present, but certainly everything we're hearing across the board globally is that it's increasing trafficking.
Dave, in light of time, I'm going to just ask one more question, unless you tell us that we should continue to. We have some other questions, but I think we might be a bit over.
Actually, I think you're good. If you want to take 3 or 4 more questions, I think we've got time. Okay, great. So I think this is a really interesting dilemma. And one of the questions that comes in, so say we have an adult trafficking victim and there's a report made and maybe that person is in a sex trafficking situation, maybe engaged in prostitution. How do we address the issue of a well-meaning report by a healthcare provider that just gets the victim enmeshed in a criminal justice system? How do we, I mean, from the legal perspective, we have some initiatives, part of our healthcare, our trafficking initiative, to look at diversionary courts and to try to increase the use of diversionary courts so that if someone's a trafficking victim and they get referred, they don't just get charged with prostitution and get cycled through and sort of don't get out of that, but rather they get referred to the right people so that they can get out of their traffic situation and not be engaged in those criminal behaviors. But Hanni, I'm wondering if you've sort of thought through that kind of situation. How do we get trafficking victims out of their situations rather than just get them in another problematic one?
Yeah, this is such an important question. And there's a number of layers here. So first of all, as the Jones Day report highlights, in most cases, adult trafficking there's not a mandate to report. There are some exceptions to that. Some of them are based on capacity, disability, et cetera. And I know that in addition to putting it on the screen, I put a link to the report in the chat. So I think that would be step number 1. I think this question also speaks to the fact that you need to have, it's not just having a plan in place that's like, okay, contact social provider for housing, generic, blah, blah, blah. You actually need, as part of that policy and procedure work that a health system does, to establish relationships with each of those kind of tendrils that of sector response, whether it be legal aid, whether it be law enforcement, whether it be housing in the community, before you have that identification step. And this is so critical because just as in healthcare, we're not all educated on what trafficking looks like and distinctions between commercial sex and trafficking and prostitution. Law enforcement also is, not 100% trained on this issue and the legal distinctions there. And maybe they might see a crime when there's actually a victim. And so knowing which law enforcement in your community where your health system is embedded are aware of those distinctions, that are trauma informed, and also know the differences between these things, is so critical ahead of time. And so this question is just another example to me of like the need to have, I feel like I've said it 5 million times, but the critical need to do no harm and make sure those policies and procedures are in place. And I would say also, even more so, we're in this kind of racial reckoning globally, and thinking about the disproportionate vulnerability to trafficking among the Black and Indigenous populations. And we also know those same populations end up being criminalized disproportionately due to just human bias or our existing structures. And so I think this question is even more important as it relates to those vulnerable populations. And then, that's like, okay, the first thing is, how do we prevent this scenario from happening? I think another piece to it, though, is there's this urgency whenever you have someone, speaking from a clinician perspective, when there's somebody in front of you who's experiencing violence and wanting to do something. And a very natural instinct that I hear over and over again is the first instinct is to call law enforcement. And I think what I advise everyone in my trainings is to first pause and to think about what your goal is in that encounter. And the goal is actually not to rescue or to get a disclosure, but it's to create that open door that they know that healthcare facility is a safe place. And so you start with that, centering that individual and what they say their needs are. And they may really just be looking for a turkey sandwich. They might be trying to access housing, and they might not be interested in legal remedies at that point. So those are my responses to different layers of how I see that question.
Mindy, I have a question for you. There was a inquiry that came in earlier from someone who works for a large pharmaceutical company, and they were interested in how could they get involved. And I'm wondering whether you're aware of any partnerships that exist between hospital association and the pharmaceutical sector that could be a place to work together on these issues.
Curt, I'm not, but we'd love to have other sectors of healthcare join us. And so if you're interested, why don't you join? I'd invite the person to join the advisory committee and participate. I think start participating, that way, and then, but as you can see from the three of us who, our three organizations and how different we are, that we would welcome partnerships with other sectors of the healthcare field to try to, provide education and resources and other opportunities to identify and to work with victims. So I think our emails are somewhere around here, but if you want to get in contact with me or Curt or Hanni, we'd be happy to invite you to join our advisory council.
The next question is one that I'm going to try to field first. So we've been talking a lot about trafficking victims as patients in the healthcare system. How do healthcare providers know that they're not actually using trafficking victims through, for example, cleaning services and others? And I think never say never, because you don't know for sure. There might be some inappropriate vendors out there who bring in people for the night crew. But in my experience, healthcare in the US is one of the most heavily regulated fields in the country. And there is there's more attention paid to making sure people are employed correctly, not using, inappropriate vendors and making sure that all of these different laws and regulations that apply to healthcare are followed. So again, that's not to say that there isn't any usage of trafficked labor in the US healthcare system, but I would say that that's not where I think the primary issue arises. I think there are other industries that deal with more transient labor, whether it's, for example, non-permitted construction or other kinds of temporary labor that might be out there where trafficked labor might be more of an issue. But that's my sense. Mindy, I don't know if you've got your own perspective on that issue.
Well, Curt, I think this is related, but we were just talking with Catherine Chan, who heads the HHS Office in Human Trafficking that we all mentioned earlier. And they actually are focusing on supply chain, on looking at trafficking in the supply chain. So I think that is that's a real role for government to help us identify actors in the supply chain who may be taking advantage of labor, sex, or any other kind of abusive trafficking behavior. And I do know that that's one of the focuses, things that they want to work on. So we certainly welcome that effort. And as I said, Catherine and her colleagues have been terrific partners in this. And we expect with the new administration that they will continue to be terrific partners. And I think that's an area where they have a lot to contribute to help us identify those kinds of issues.
Okay, the last question, and then I'm going to turn it back over to Dave.
Can I just say
sure.
one thing real briefly?
Sure.
As you said, healthcare in general in the US context is highly regulated, but there are parts of the healthcare sector that end up being less regulated. And there have certainly been cases of like importing Filipinos where they were promised jobs as nurses, and some of them were nurses in like skilled nursing facilities, for example, where there can be trafficking there. So, and then, if you add another layer of like labor recruiters to any labor supply chain, there's always the potential that labor recruiter, while the healthcare system may not be aware of it, they're just trying to fill in X, Y, or Z job, that there could be that potential. And I echo Mindy's comments on supply chain. Thankfully, because of our CBP protections in the US, we didn't bring in like slave labor made Malaysian gloves during this COVID crisis, but countries like the UK did. So we're speaking from the US context, we have some policies that have really protected us from that.
And that's why I love being part of this group, because I think of it from my perspective of who do we represent? What kind of healthcare providers do we represent? And Hanni shows that there's a whole other sector out there that may not be coming to Jones Day as clients, but are part of the healthcare system. So we should be thoughtful of those as well. So final issue, Hanni, maybe you can take the lead on this one. What are the types of providers, whether it's dentists or healthcare or psychiatrists or substance abuse detox kinds of facilities that you think are where we have the most need for providers who can assist with trafficking victims who are identified and then need to be referred?
Why are you making me choose?
All of the above.
Yeah, I mean, this is where we need more research. I would say that there have been a couple of studies that have like asked that question, and they're relatively small studies. And I would say emergency departments, not surprisingly, OBGYN is another group, if you were just going to kind of go numerically, proportion wise, and then psychiatrist and substance use in the US context. So.
Okay, Dave, I think we have gone past our allotted time, so appreciate having us here. Really appreciate everyone's attention, and again, I really appreciate both Hanni and Mindy's work in this area, and looking forward to continuing to work with you as we take these issues forward.
Well done. What a great panel. You actually were right on time, so perfect. Thank you very much. Incredible panel and wealth of knowledge, and we look forward at Rotary to working with you to expand your mission, so to speak. Good deal. Thank you so much.